Hello one and all, I'm Dr. Srushti. I'm a Pediatric Ophthalmologist from Shekar Eye Hospital. Today I'm going to talk about congenital eye defects in babies. So congenital eye disorders are the eye defects that are seen at birth and occur due to defective formation of a particular structure of the eye. Our eyeballs start developing at 3 weeks of gestation, that is intrauterine life, while within the womb, and eventually develop structure-wise and are fully formed by 38 weeks of gestation. So any interference that happens during this period may cause a congenital eye defect. What could be these interference? It could be either maternal infections or consumption of teratogenic medications that could affect various structures in the baby, or it could also be toxicity due to drug or alcohol abuse in the mother during pregnancy. These can be vision threatening or could bother the child with other symptoms like eye irritation, watering, trauma, or infections, or could simply be a cosmetic blemish. Some of them can be treated entirely. Some of them can be definitely improvised, but some of them have to be rehabilitated. So let me give you an overview of what eye defects can be seen at birth structure-wise. So this is a picture showing normal eyes. Eyelids as a congenital eye defect can present with a different in position, or the lid margin can be turned inwards or outwards, or the formation of the entire lid can be defective. So one of the common lid anomalies seen at birth could be congenital ptosis, wherein the position of the upper lid can be quite droopy, and so much so that sometimes in severe form it could be obstructing the central part of the cornea also. In such cases, child might be facing a vision problem. So in order to overcome that vision problem, child may be adopting a chin up position so that they can see through the lower part of the open palpebral fissure, or child may, if in case of unilateral cases, or if one eye is affected, or if it is too much affected, the drooping is too much, the child might just ignore that eye and might be fixing with the other eye alone, which is normal, and that eye may end up with a lazy eye. This lazy eye happens because of the deprivation of the stimulus or the visual stimulus reaching the nerve of the eye. So congenital ptosis can be treated with a plastic surgery by elevating the droopy eyelid, and this can be planned accordingly whether or not it is vision threatening. If it is vision threatening, it has to be done early in childhood. If it is not vision threatening, or if the child is comfortably adapting a mild chin up position to manage and the vision is not affected, then the surgery can be postponed to later in life for the cosmetic purposes. So apart from ptosis, eyelid anomalies also accompany certain other anomalies like shortened palpebral fissure horizontally along with the ptosis and along with an extra fold of skin. This syndrome is called blepharophimosis, ptosis, and epicanthus syndrome. Epicanthus is the extra fold of skin at the inner angle of the eye. And overall, this forms a very small palpebral aperture for the child to see. Again, this could be vision threatening or not. If it is vision threatening, the child has to undergo a plastic surgery to enlarge the palpebral fissure in a younger age, or if it is not vision threatening, it can be waited for little older age. So this epicanthus, what I told, the extra fold of skin, can even present as isolated thing. It could be actually making the eye appear like the eyes are deviated inward. That is called pseudo squint, wherein the child will not have actual squint, but it makes the eyes look like they are inward deviated because this part of the white area is covered by an extra fold of squint. Then there is another thing called Epiblepharon, wherein the extra fold of skin is present just next to the lid margin. The clinical significance of this is that the epiblepharon can be causing the actual lid margin to turn inwards so that the lashes are rubbing on the cornea. So this minor trauma that happens to the cornea can cause repeated irritation, watering, and corneal infections also might be a risk factor. Other than this, the eyelids can present with something called inturned or outturned lid margin, which is called Entropion or Ectropion. Entropion, the risk is that the lashes will be rubbing on the cornea. Ectropion, the risk is that the closure of the eyelid may not be appropriate enough, so that there could be drying of the intraocular structures or the cornea basically. Other than that, there could be improper separation of the eyelid while development, and hence there can be some sticking ends of the lids, making the child unable to open the eye properly. Coming to the next structure called orbits. Orbits are the bony sockets in our skull bone where the eyeballs are seated, and this is a pyramidal shaped socket, and sometimes maldevelopment in this bony sockets can cause something called exorbitism or hypertelorism of the orbit, wherein they are placed quite widely. The clinical significance is that this can be associated with many other structural malformations in the other parts of the skull bone, and this could in fact cause compression of the optic nerve where it exits the orbit and gets into the skull. So this could be actually vision threatening. Another thing is that there could be improper closure of the eyelids, and hence exposure is also a risk in such cases. Coming to the lacrimal system. So what happens, the tears in the eyes are normally drained into the nose through the ducts called canaliculi, and through the lacrimal sac, and through the nasolacrimal duct into the nose. Sometimes there is a maldevelopment in this structure causing blockage, and most common type of blockage is nasolacrimal duct obstruction, wherein parents bring the babies with complaints of excessive tearing, which could be either in one eye or both the eyes, which is present since birth. And there also can be some collection of the discharge in that eye. So the treatment for this would be massaging on the area just nasal to the inner angle of the eye, so that the sac which is collecting the tears is massaged, and the pressure which is transferred by the massage tends to open up the blocked duct. If this usually 90% of the times recovers or opens up when done within 1 year of age. And beyond 1 year of age, if the block is not opened, then it has to be intervened and opened by something called probing, or it can be even operated for at around 4 years of age. The blocks can be elsewhere, like in canalicular block, or the opening itself can be blocked, called as punctual or canalicular atresia. So other than this, there can be an opening in the skin around here, and the tearing can be coming out from there. That is called nasolacrimal fistula. Let me shift to the next structure of the eyeball, that is the eyeball itself, the globe. So the globe is attached to muscles which are responsible for the movement of the eye and position of the eyes. The eyeballs are oriented parallel to each other normally, and any variation in this orientation causing inward or outward deviation, or sometimes up and down deviation, is called squint. So squints can appear at birth or around 6 months of age, is called congenital squint. And what is the clinical significance? Is it only cosmetic? No. Squints can be associated with lazy eye, which is a major cause of vision problem in squint. So congenital squints are usually large angle, And if one eye deviation is constant and the other eye is straight, children tend to adapt to seeing from the straight eye alone, and the lazy eye sets in the deviated eye. Squints can be corrected surgically under general anesthesia, and if it is a large angle, it can be done as early as 1 to 1.5 years of age. So the squint surgery is mainly oriented towards vision and binocularity, and not only cosmesis, and hence it is important to get it done in the early age. Apart from this, there is something called Nystagmus, which is constant shaky eyeballs. This can be present since birth, wherein we call it as congenital motor nystagmus, and this is usually associated with decreased vision in both the eyes, and sometimes the speed of shaking in the eyes reduces in one particular direction of movement, and in that position child would prefer to see clearly. Hence, the child would prefer to adapt an abnormal head positioning, either in the form of face turn, chin up or down position, or head tilts, in order to make the vision clearest when the speed of the shaking is minimal. And hence, this nystagmus can be associated with a prominent abnormal head positioning. Although nystagmus cannot be completely cured, the speed usually tends to reduce over the years as the child grows. Also, if the abnormal head positioning is quite significant, then we can operate on the muscles of the eye, just like squint surgery, to reposition the eyes in such a way that speed of the nystagmus is minimal in the primary position, that is straight position, so that the child could at least get rid of the discomfort of keeping the head in an abnormal position. Nystagmus surgery is usually done later in childhood, so that we wait till the speed comes down on its own as the child grows. So other things regarding the formation of the globe is the size of the globe. So the globe can be even small sized, or the small sized with an abnormal structures inside the globe. So a normal small eye is called nanophthalmos, wherein the intraocular structures are accordingly balanced to form a normal seeing eye. It's just a small eye but functions normally. But there is another thing called microphthalmos, wherein the smaller size of the eye has affected its functioning also. And there is also something called Enophthalmos, where the formation of intraocular structures is also faulty, and eyeball is just like a cyst. Coming to the next structure of the eyeball, that is the outer layer of the white part of the eye, that is called conjunctiva. It is usually transparent, and the congenital anomalies in that is that there can be some melanosis, that is pigmentation of that layer, that is harmless. The important structure we need to concentrate on is the cornea, that is transparent part of the anterior segment of the eyeball. In this model, it is not there. The anomalies in cornea could be in the form of a loss of transparency, which is called corneal opacification. This will definitely affect the visual acuity, since the cornea forms the anterior-most barrier of the globe in the visual axis. So, if the opacification involves the center, then the light would not be reaching the nerve properly, depending on the density of the opacification. If the opacification is quite dense, then the nerve will not receive any clear image, and that eye would definitely go amblyopic, or lazy eye would set in. So, if the opacity is involving the entire cornea, then probably that eye will not be able to be rehabilitated. But if the opacification is involving only the center and the peripheral area of the cornea is clear, then we can operate from the inside of the eye to make an opening in this muscle called iris, in the structure called iris, and make another opening in the side, so that the light reaches through the side to the retina. It would definitely give a better vision. The other option for such corneal opacities is corneal transplantation. But since in children the response to any injury like an inflammation or a reaction is quite severe, the rejection of the graft that is put is quite high. So, corneal transplantation is a complicated decision to take for a surgeon or for the parents and the family. So, it is usually not a preferred choice in very young children. So, other than corneal transparency issues, the size of the cornea can also be altered in congenital eye defects. Sometimes there will be a microcornea, sometimes there will be a megalocornea. So, normal corneal diameter is around 10 mm. And if there is a microcornea, the size as such will not cause any problem, but it is usually associated with other anomalies inside the eyeball, which could actually be vision threatening. So, microcornea can be associated with a smaller anterior chamber or the space inside the eye. And there can be associated lens anomalies and posterior segment anomalies also. If there is a megalocornea, this has to be differentiated from a cornea which has become bigger because of the intraocular pressure, which is called congenital glaucoma. Megalocornea as such is not a problem, but if it is a congenital glaucoma, then it is definitely immediately vision threatening. So, other than this, there can be on the cornea, there can be a mass growing, which is usually involving the edge of the cornea, which is called dermoid, that is commonly seen. Moving on with the next structure of the eyeball, that is iris. Iris is a pigmented muscular structure or a layer which separates the anterior chamber, which is the space behind the cornea, and the lens. This is the crystalline lens. This iris will have an aperture in the center, and while the eye is growing inside the mother's womb, there will be a membrane occluding this aperture, and which eventually disappears at birth. Sometimes there can be remnants of this membrane in the form of thread-like structures, which is called as persistent pupillary membrane, which is one of the congenital eye defects. This persistent pupillary membrane is usually visually insignificant. Sometimes, very rarely, the pupillary membrane can be so dense that it can in fact occlude the center of the visual axis. So, this aperture is nothing but pupil, which allows the light to pass through the cornea, through the lens, and reach the nerve. If there is a membrane in front of it, like a persistent pupillary membrane, that would in fact obstruct the flow of the light, and this would be the cause of dense stimulation deprivation of vision. Along with that, the other congenital anomalies of iris could be in the form of change in color. So, there can be hypochromic iris, which is lighter colored iris. It can be entire iris involved, or there can be a sector of iris involved. Other than that, there can be some adhesions or loss of separation of the iris from the cornea in front. So, these adhesions in fact can cause congestion in the anterior chamber and block the outflow tract of the fluid inside the eye, and hence could be the reason for glaucoma in that eye. So, there is something called aniridia, wherein the formation of this entire iris itself is absent. There will be a very small frill of iris in the periphery, but it won't form the entire structure. This could be associated with various other problems in the body also. Moving on to next structure, that is a crystalline lens. This is the crystalline lens model. This is placed just behind the iris, and this is kept in place by the thread-like structures called ciliary zonules. And this lens is transparent and it keeps changing in its anteroposterior diameter or in its size and shape by the muscles that are attached to those thread-like structures, and this is responsible for our focusing mechanism. So, what are the congenital anomalies that could happen in lens? Very importantly, pediatric age group can also present with cataract. In fact, congenital cataract or the cataract that is at birth, that is there at birth, is very much visually significant because it can cause dense amblyopia or dense lazy eye formation. That if we delay the treatment, there is a chance that vision might not in fact improve. So, congenital cataracts are responsible for around 10% of childhood blindness and have to be importantly treated. Congenital pediatric cataracts can be unilateral or one-sided, one eye involved, or bilateral, both eye involved. It can be hereditary or non-hereditary, which is called sporadic. It can be just isolated, just cataract can be there, or it can be associated with other problems in the body or the eye. So, this cataract can be total or partial also. If there is a congenital cataract, it has to be treated as early as possible, by which I mean, if there is a bilateral cataract, if the both eye is affected, has cataract, then we would prefer to do a cataract surgery at around 8 weeks of life. If there is a unilateral cataract, if one eye is affected, then there is more hurry because the other eye has a good vision and the brain has a tendency to get adapted to the other eye alone. So, we need to clear up the visual pathway of the cataractous eye as early as possible. Hence, we prefer to operate as early as even 6 weeks of life. So, congenital cataract, if it is operated that early, we cannot place the artificial intraocular lens after removing the cataract because in the first year of life, the eye growth is drastic and we cannot predict the outcomes after placing the lens at that age. So, we wait for some time and do a secondary surgery to place the intraocular lens in congenital cataract when the surgery is done within 1 year of age. Along with that, there is also a risk of more complications on placing the lens in congenital cataract in the first go. Apart from this, what else could be the congenital anomaly of the crystalline lens is that the position of the lens. So, lens is exactly positioned in the central visual axis right behind the iris and pupil normally. Sometimes there can be a displacement or dislocation or subluxation, what we call, of this crystalline lens, although the transparency is still normal. So, this subluxated lens or lens which is moved from its place could cause some major visual problems and hence it has to be operated for also. So, the subluxated lens is removed and the artificial intraocular lens is placed after the surgery. So, coming to the posterior segment, the structure behind the lens is a transparent jelly-like structure which occupies the entire globe, which is called vitreous body. So, vitreous body or vitreous humor, it is a transparent structure. It doesn't have any other structures within it normally. In a developing eye inside the mother's womb, there will be a vessel or an artery called hyaloid artery which runs through the center of this vitreous body, which supplies the capsule of the crystalline lens, which eventually undergoes regression and disappears. Sometimes there can be a persistent such hyaloid artery. We call it as persistent hyperplastic primary vitreous, which could form a stalk, an opaque thread-like stalk attaching the optic disc to the posterior part of the lens. This could be involving the center of the lens, and that could be the cause of a cataract, or that could be the cause of visual obscuration in the visual axis. So, in such cases, when seen after birth, it needs to be treated, since it could be visually affecting. Sometimes it could be as small as visually insignificant also. In that case, we would not prefer to operate. Other than that, coming to the posterior segment, that is the first layer, which is retina. Retina is an important neural structure of our eyeball. The congenital eye diseases which can affect the retina could be in the form of Leber's congenital amaurosis, or Noory's disease, or congenital stationary night blindness, foveal hypoplasia. So, fovea is an important structure which is in the center of the retina, which is responsible for the precision of our vision. It forms the central, the most clear part of the vision. Coming to the next structure, which is optic disc. Optic disc is the front part of the optic nerve which attaches the eyeball to the brain. So, optic disc anomalies could be in the form of optic nerve head pit, where there is a pit in the optic nerve, or the formation of the optic nerve head itself could be small, which we call it as optic nerve hypoplasia, or there is something called morning glory anomaly, wherein there is a excavation of the entire optic nerve head. All these may or may not be visually significant according to their extent of defect. So, with this, I think I have covered most of the congenital eye defects, which are important and common also. As you would have noticed, the nature of congenital eye problems are varied, and some of them can be treated, some of them can definitely be improvised, and some need rehabilitation. All we can do is early detection and prompt treatment, so that we can help the affected child in long term. Take care. Thank you.